The Nebraska Cancer Research Center, in partnership with Bryan Health, Nebraska Hematology Oncology, St. Elizabeth Regional Medical Center, and Southeast Nebraska Cancer Center presents.
I'm Dr. Stacy Knox. I'm an oncologist and work at Southeast Nebraska Cancer Center and enroll cancer patients for clinical trials at the Nebraska Cancer Research Center. Today I want to discuss metastatic colorectal cancer. Metastatic cancer is spread beyond the place where it started, usually into places like the liver and the lung, and this is not usually a curable situation. Doctors like myself in this situation give chemotherapy in order to help patients live longer as well as to have a better quality of life. In the mid-1980s, my grandfather was diagnosed with colon cancer that had spread to his liver. As we will be discussing, there were very few treatments available at that time. And he quickly developed worsening cancer in his liver, becoming weak and jaundiced within a few months of his diagnosis, and then he passed. My entire family was irrevocably altered by his loss. We had so little time to come to grips with his disease and what was happening to him in such a short period of time. I can't say that at that time I knew I would grow to become an oncologist, but it has provided me with a unique perspective with having the knowledge of the incredible advances that have been made in the treatment of colorectal cancer since the mid-1980s. For decades, 5-FU, which is an infusion IV medication, was the only active agent for the treatment of advanced colorectal cancer. In the year 2000, everything began to change with the FDA approval of two medications, irinotecan and oxaliplatin. This was shortly followed by further medications, bevacizumab, cetuximab, and panitumumab in the following years. In the 5-FU era, overall survival was 11 to 12 months. Beyond 5-FU, patients would be enrolled in trials in order to find additional treatment options. In this new era, we see survival measured in years, and it easily doubles the overall survival seen in the 5-FU only population. 5-FU was a medication that was used to treat colon cancer and is usually given as an infusion that is given over time, 24 hours, 48 hours, and it's slowly infused. As a single medication, it has minimal treatment effect in a colorectal cancer patient, explaining the survival times that we have seen in the past. In this new era of treatment, 5-FU is still a part of our treatment, but it is now added to stronger medications. It is the backbone of our treatments that are available now. The first medication we are going to discuss is oxaliplatin. Its role was established in the U.S. intergroup trial N9741. The combination medications was called FOLFOX4, and this includes 5-FU, leucovorin, and oxaliplatin. This combination of medications was proven to have a better response rate in shrinking tumors, time to progression and growth of tumors, and a median survival time, which is the average time of survival of the patient after the patient starts treatment. With this combination of medications, we saw patients surviving about 19.5 months after they were started on treatment versus the 11 to 12 months with infusional 5-FU alone. From that time on, the FOLFOX was considered to be the standard of care in metastatic colorectal cancer patients. Since then, modifications have been made in dosing for best responses and tolerance to a regimen that we now call FOLFOX6. It provides a 21-month median survival. Other trials have occurred since that time and have concluded that this is our best regimen. The next medication is irinotecan. It appears to be as effective as oxaliplatin. Fulfuri is used in a combination of medications. Irinotecan is used in a combination of medications called Fulfuri. It's 5-FU, leucovorin, and irinotecan. The survival with this combination is 21 months for an average. It's considered an acceptable first-line therapy treatment versus oxaliplatin-based regimens. Now we have two combinations that are active and provide much better control than 5-FU alone. There's much better outcomes in this situation. And also of interest for oncologists, with these two regimens, we have very different side effect profiles. So if you have a patient who there's concern for the potential of nerve damage or diarrhea, you could determine which medication regimen would be better based on these side effect profiles. Also, if you started with FOLFOX and did not have a beneficial outcome or shrinkage of your tumor, you could change to Fulfuri, and hopefully you would have a better response, because these are very different chemotherapy regimens and they work on the cancers very differently. FOLFOX and Fulfuri are the building blocks to which we add newer treatments that are now available. These combinations are given at an infusion center, such as a cancer center, through a special IV called a port that is placed under the skin. The first day of treatment is done at the center, and the patient will get chemotherapy for 3 to 4 hours. When they leave the office, they will then have an infusion line placed in the port, and they will have a continuous infusion for 24 to 48 hours. This is a very low dose of chemotherapy that's continuously infusing into their body, and I sort of think of it as crock-pot chemotherapy. They're sort of stewing in it. The side effects of the chemotherapy, as I mentioned, are very different between these two regimens, but both FOLFOX and Fulfuri are very well tolerated, and we see patients well into their 80s who are able to manage these medications as long as they don't have a lot of other illnesses to handle. Now I am going to discuss one of the largest breakthroughs that have occurred in cancer treatment ever, not just colorectal cancer, but cancer treatment ever. A novel treatment designed to treat cancer cells, more specifically, and tumors through their need to develop a blood supply. Previously, chemotherapy was made to target rapidly dividing cells, which are found all over the body, and is why many chemotherapy medications cause hair loss and nail changes, nausea, vomiting, etc. But bevacizumab, which was FDA approved in 2004, is a humanized antibody that is similar to immune attack your body makes on a virus, and attacks the vascular endothelial growth factor A. And right here on this diagram, you see this arrow, and that is the VEGF protein. When that is destroyed, angiogenesis is the growth of blood vessels to the tumor. A pivotal trial was conducted with 5-FU and bevacizumab and improved response rates in the shrinkage of tumors and overall survival of about 20 months. Remember, this is 5-FU and bevacizumab. 5-FU alone was only had a survival about 11 to 12 months. Since then, the benefit has been confirmed when adding bevacizumab to FOLFOX and Fulfuri with the oxaliplatin and irinotecan containing regimens. This shows an interesting aspect of clinical trials the world over. Here, the bevacizumab was combined with 5-FU, which in 2000 we had learned was not the standard of care anymore. Using combinations of FOLFOX and Fulfuri was considered the standard of care, but when this trial was written, the results of the other trials hadn't been learned, and the trial could not be changed. So when the trial was published, new trials had to be designed in order to determine whether the same results could be seen with oxaliplatin containing regimens and irinotecan containing regimens. This has been done, the results have been confirmed, and now the combination of FOLFOX and bevacizumab for many would be considered the first treatment given to any newly diagnosed metastatic colorectal cancer patient. Here we discuss another unique antibody therapy treatment. This is another antibody, although this one is directed at the growth of epithelium, which is a surface type of tissue found throughout the body and is important in the growth of cells and cancer cells. Cetuximab is an EGFR inhibitor, and the CRYSTAL trial revealed the benefit among patients who have normal KRAS, which is very important and is necessary for cancer cells to grow. Overall, survival was 23.5 months when given with FOLFIRI. This combination provides the best response rates in tumor shrinkage compared to other regimens, and it also increased the possibility of curative resections when possible. There are times when patients have one lung metastases or one liver metastases where our goal is actually to shrink it down to take a patient to surgery, and there is a possibility of cure. This doesn't happen often, but the combination with cetuximab does provide us with that option. This does not work on patients who have a mutation in their KRAS. On this next cartoon here, you can see the protein RAS is very closely associated with the VEG, and you can see how very closely the medications are to each other. If RAS is not normal, the Erbitux will not work. The RAS, when this is normal, disrupts the level, at this level, impairs cell survival and proliferation. And so cancer cells cannot grow properly. The next drug is panitumumab. This is very similar to Erbitux and is also an EGF inhibitor. It also works on the RAS pathway that I just showed you. The PRIME trial revealed the benefit of adding this to FOLFOX. It improves response rates to 55%. There's a longer progression-free survival. The FDA currently labels it as a single-agent medication, as other trials later done revealed it was too toxic to combine with FOLFOX. It's also useful in patients who only have normal KRAS. It won't work with mutations in the KRAS. Many of us will use panitumumab on patients who are worn out and tired and can't handle combinations of chemotherapy anymore. By itself, it does not work as long, but patients feel very good on the medication. And there are some patients who have very long, durable responses in their cancer. So it is still a popular drug to try at some point during the treatment of colorectal cancer patients. In 2012, we saw the FDA approval of 2 new medications for the first time since 2004. The first was a medication called aflibercept, which is a VEGF trap. This acts as a decoy receptor that binds to VEGF-A and B. It sort of wraps around these areas and prevents the activation, and that's why it's a trap. The VALOR trial took patients who were refractory to the oxaliplatin we spoke about earlier and treated them with FOLFIRI and aflibercept, or a placebo. There was a small improvement in the overall survival of these patients of 13.5 months versus 12 months. One question we have right now is, how should we use aflibercept? Should we use it as soon as patients fail with oxaliplatin or are resistant or intolerant to oxaliplatin, or should we maximize our other VEGF medication, bevacizumab, with other combinations such as FOLFIRI, and then go to the trap? And that's something that we're going to have to work with and continue to have trials. But this is a very useful medication. The final medication to be discussed is regeraphenib. It's an inhibitor of angiogenic tyrosine kinases, which is the growth of blood vessels, as well as other receptors and intracellular kinases. It's fondly referred to as the dirty bomb. It's approved based on the results of the CORRECT trial. It was compared with best supportive care or support and regeraphenib. Best supportive care is pain control and other supportive measures, but no chemotherapy. Regeraphenib is an oral medication. This trial took patients who had had a lot of chemotherapy previously. Now, when they have had a lot of chemotherapy, it means they're much less likely to have responses to more chemotherapy, and those responses are less likely to be as durable and provide as much survival benefit. In this population of patients, and despite the refractory population, we did see that there was an improvement in median survival to 6.4 versus 5 months. Now we can look at the difference of the survival that has changed over the decades as we have inherited new treatments for cancer, colorectal cancer. Back in the 80s, when there was very little or no treatments for colorectal cancer, the survival was 6 months. As we added oxaliplatin and irinotecan, survival improved to about 11 to 12 months. As we added the antibodies, bevacizumab and Erbitux, we saw improvements in survival depending on the trial to 14 to 16 months. And now with newer medications, survival has improved to over 20 months. As this continues to improve, we'll see years and years be added to the patients, is our hope. But there is more to be done. Here at the Nebraska Clinical Research Center, we have 3 trials currently available. There is a first-line treatment in elderly patients with metastatic colorectal cancer patients who we evaluate the use of bevacizumab with oxaliplatin-based treatment versus 5-FU-based treatments. Then there is a stage 3 colon cancer trial evaluating whether 6 versus 12 treatments with FOLFOX are necessary in resected patients. And finally, we have a phase 2 study of irinotecan and cetuximab with or without a new antibody called ramucirumab in advanced KRAS wild-type patients who have progressed on bevacizumab-containing chemotherapy with metastatic colon cancer. Well, thank you very much for taking this opportunity to learn a lot more about colorectal cancer in the metastatic setting. I hope this has been informative for you. Thank you very much.
Home is where you celebrate life. Home is where you spend time with loved ones. Home is where you cheer for the Huskers. And when you're diagnosed with cancer, home is where you want to be. The Nebraska Cancer Research Center offers hope right here at home in Lincoln. Ask your doctor about participating in cancer research. The Nebraska Cancer Research Center. There's no place like home for clinical trials.